This is again that same diagram. We have discussed the various factors: increased afterload, increased preload, resulting in gradually declining myocardial function, and then activation of the neurohormonal system, and again increasing further vasoconstriction, which further increases the afterload, and fluid and sodium retention, which will further increase the intravascular volume. So coming to the management of chronic heart failure, stage A is the preventive therapy. Here risk factors can be modified and indications to suspect heart failure. When these stages are, there are various stages. So in this stage, there are only risk factors for heart failure, and what are the indications to suspect that there can be there is a risk for heart failure? There are hypertensive patients, diabetic patients, patients with elevated BMI, the coronary artery disease patients having atherosclerotic disease like evidence of peripheral vascular disease or any event of cerebrovascular disease, then patients with valvular heart disease, first degree relatives with heart failure patients, then cardiac toxin exposure history, or the presence of obstructive sleep apnea. Or when we are in some tests, we find presence of arrhythmias, or the ECG is abnormal, like signs of LBBB, LVH, Q waves are there, or the chest X-ray shows cardiomegaly. These are the patients where we should suspect risk of heart failure, and here at this stage we should start preventive therapy. Indications to assess cardiac structure by echocardiogram. When should we go for echocardiography? So patient with coronary artery disease, patient with valvular heart disease, the first degree relatives of a heart failure patient, then supraventricular tachycardia, either atrial fibrillation or flutter, or patients with abnormal ECG having LVH, LBBB or Q wave, or presence of VT or VF in any ECG, then chest X-ray showing cardiomegaly. All these patients should undergo electrocardiogram. Routine evaluation of BNP for asymptomatic patient evaluation is not recommended. ACE inhibitors are recommended for the prevention of heart failure in the patients at risk. Now coming to stage B. These patients have structural changes. The first stage A was just having the risk factors, but these patients, they have some cardiac structural changes, but they have not yet developed heart failure symptoms. In such patients, it is important to determine the etiology with particular attention to reversible causes, including coronary ischemia. Coronary angiography should be considered when pre-test probability is high, as can be assessed by TMT or other tests. Then lab testing for unusual etiologies of heart failure is recommended if no cause is identified. Endomyocardial biopsy. This is only recommended in cases of rapidly progressive clinical heart failure with severe heart block or arrhythmias. Also, it is important to identify any exacerbating factor for heart failure or comorbidities which can influence the therapy and can be a barrier to the adherence of the therapy. The treatment recommendation also should include smoking cessation, optimal BP control, avoiding deconditioning, and alcohol abstinence if there is previous history of excessive alcohol intake. For pharmacological therapies for asymptomatic patients in which the LV ejection fraction is less than 40% includes ACE inhibitors and beta blockers. Now coming to stage C. Here there are those patients having structural changes along with some symptoms. They have developed symptoms. So all recommendations for stage B heart failure patients apply here also. The NYHA functional classification will determine the pharmacological and device therapy in these heart failure patients. Degree of volume excess, that is a key consideration in the treatment of heart failure. ACE inhibitors and beta blockers are recommended for all the patients, as we have seen in stage B also. Then aldosterone antagonist and desoxyn should be reserved for those patients who are class 3 to 4 according to the NYHA classification. Utilization of implantable cardioverter defibrillatory for primary prevention of sudden cardiac death in heart failure patient improves survival significantly. So these patients should be screened, and when the conditions are there, so we should go for ICD. If there is severe refractory heart failure and life expectancy is less than 1 year, then ICD is not recommended. Biventricular pacing seeks to improve and synchronize ventricular contraction, and this results in less mitral regurgitation and increased diastolic filling time with improved cardiac output. Now coming to stage D. While there has been a significant positive impact on heart failure outcomes with the advent of new pharmacological approaches to the treatment, the disease still remains burdensome. End-stage heart failure patients have poor quality of life, they have frequent hospitalization history, then higher mortality despite the optimal medical management. The possibility of salvage by medical therapy alone at this stage is remote. So the goals of therapy differ from those in stages A, B and C. And here this includes palliation of symptoms and hospice also, reducing rates of hospitalization, and in subjects who are eligible, cardiac transplant or left ventricular assist devices is opted for. In patients with history of recurrent admissions, inotropic therapy should be considered as a bridging to transplantation or LV assist device, or as part of the hospice period. Now coming to the indications for heart transplantation or LV assist device evaluation. The absolute indications are for hemodynamic compromise because of heart failure, if there is presence of refractory cardiogenic shock, the patients are inotrope dependent, the peak VO2 is less than 10 mg per kg per minute with achievement of ventilator threshold. There are severe symptoms of ischemia and refractory angina which is not amenable to revascularization, and presence of recurrent symptomatic ventricular arrhythmia. Relative indications are peak VO2 11 to 14 mg per kg per minute or around 55% predicted, and major limitation in performance of daily activities, recurrent instability of fluid balance or renal function is not due to patient or renal function which is not due to patient non-compliance with medical regime. Few indication which was not very appropriate, that is we don't go for this. There are only presence of low left ventricular ejection fraction alone, functional class 3 or 4 heart failure, peak VO2 if it is more than 15 mg per kg per minute, and there are no indication. Here they are not very much appropriate indications, but it depends on the individual choice whether to go for this or not. Thank you.